Kia ora koutou. I am Kate Barbie, Support Coordinator for Fertility New Zealand. It's my pleasure to welcome you tonight to Fertility Week's webinar, The Cost of Infertility. This year's fertility campaign is entitled I Am 1 in 4. Any of us can face challenges building whānau. 26% of Kiwis face infertility during their lifetime, affecting men and women equally. It can impact any New Zealander, regardless of factors such as ethnicity, education, urban, rural, and religion. The campaign aims to support and educate people who are currently trying to conceive, reduce stigma, and raise awareness amongst people who are affected in the future. For those of you not familiar with Fertility New Zealand, we are a registered charity and we walk along all people facing fertility challenges. We have a dedicated helpline and we provide support, information, and guidance to anyone at any stage of their journey. Check out our website for more information. Tonight's webinar, The Cost of Infertility, is brought to you by Greg Phillipson, who is a fertility specialist and Fertility New Zealand board advisor. So thank you for being with us tonight, Greg.
Okay.
If you have any questions for Greg throughout the webinar, please fire them through. You can post those questions on the webinar or Facebook Live. We'll be checking in on both platforms and we'll bring those questions to Greg throughout the through the presentation. So thank you for joining us tonight. Tonight is our last webinar for the series. I hope you have enjoyed our webinar series for Fertility Week, and I'm looking forward to tonight's webinar. So over to you, Greg.
Thank you. I just want to introduce myself a little. As Kate has introduced me, I am the advisor to Fertility New Zealand. I still work as a specialist, but I'm not directly affiliated with any of the private fertility clinics in New Zealand. I've previously worked with them and also worked extensively overseas, particularly in Australia. What I want to do tonight is try and give some introduction to some of the issues about costs. I realize there's a lot of emotional cost and other costs that people go through to undergo any health treatment. But today, I'd like to talk about how there is public funding and how that is assessed to make it proceed and what one goes through to be assessed, but also to talk about some of the private costs and what it means to see a private specialist for fertility care. Briefly at the end, I'll discuss 2 or 3 of the common scenarios that are often the reason for referral and how they might be treated or how they might undergo public assessment. If you do forward questions, I'll try to answer them during the talk, or otherwise, if they're off the particular slides that I'm looking at, we may defer them to the finish. There are indeed some good websites available directed just for New Zealand care. The government indeed provides good advice and it's independent, particularly as it is involved with funding the public care. Also, the Fertility New Zealand webpage has links both to government and private clinics. The health boards in each region normally have good information for both those wishing to have treatment, but also for general practitioners. And a lot of general practitioners are very busy with so many different problems that they use these guides, these health pathways, in order to make sure that the appropriate tests are done to get people seen in the public system or to have tests available so that that first appointment will be more useful. The private clinics all have web pages, and if one was to put in search criteria for Fertility Associates or Fertility Plus or Repromed, you will find a lot of information that is being provided by the clinic, usually about both public and private care. I'll deal with public funding first. And one of the things that first arises is this first specialist appointment. It is funded by the health boards, and it requires referral from a general practitioner or by any other specialist that has seen you. It doesn't mean in itself that you'll necessarily proceed to treatment. And even to have that first specialist assessment, there are certain criteria that need to be met. I've listed some of them here. In particular, couples may need to have been planning a pregnancy for 12 months. That doesn't mean precisely using scientific methods or a calendar. It just really means how long ago was it that you used contraception. And in that way, sometimes people may have stopped contraception 2 years ago, and that is the key time that will be taken into account. There are some important things regarding each partner. Women will only be treated if they are under the age of 40 at the time of referral. They also are asked to provide height and weight details, because for those women that are underweight or overweight, we know there can be reasons that interfere with fertility that will improve the outcome of pregnancy if those weights can be brought back into the normal range. So body mass index will be measured. If you have questions about that, it's often available online, but any general practitioner or nurse would be able to explain it. A body mass index is also taken for the male partner. We realize that as women get older, fertility changes, but it also changes for men. And so the man would need to be under the age of 55 years at the time of referral. Also, past medical history comes into the assessment. And for those couples who have 2 or more children living with them, there is some variability amongst health boards, but it may be only those children aged less than 12 affect that assessment, but it will be asked by your general practitioner before that first appointment with a public specialist can be planned. Finally, people do need to be New Zealand citizens or New Zealand residents, and it means that this will be asked, and sometimes a passport or proof of that residency will be required to undergo care in the public care system. Smoking is something that affects fertility for both men and women, and if you are a smoker, it prevents going further to that assessment. You should be a non-smoker for at least 3 months in order to maximize the best outcome for pregnancy, and that's what's required at that referral. Each patient will be assessed on their eligibility. There are some situations, such as same-sex couples, where the woman has already been undergoing private treatment, such as donor insemination, or single women who have had donor treatment or have had investigations which indicate there could be a biological reason why pregnancy is not occurring. These couples or women still need to be under the age of 40, and the BMI guidelines and smoking status also apply. My apologies. For a private first appointment, clinics often offer a telephone consultation with a nurse or a doctor for up to 15 minutes to briefly review the history. But usually, an appointment with a specialist will cost of the order of $200 to $300. And at that time, a thorough history will be reviewed, often with a questionnaire before you even undertake the appointment. And both partners are expected to attend, and together with the test that may have been arranged by their own general practitioner. The further blood tests are required. As with the tests arranged by the general practitioner, there are usually no charges. One particular test, the AMH test or egg timer test, may have a fee. Some health boards do cover the cost. Others bill of the order of about $100 just for that test. Ultrasound scans that have been arranged by your general practitioner may not have had any fee, but if they're requested by a specialist or performed at the clinic, along with tests such as semen analyses, there may be a charge. What is not covered and what is covered in public funded treatment hinges on that referral. If someone is eligible for public funded treatment, there are no further charges for the consultations that take place at the clinic, even though they are being cared for at a clinic that provides public and private care. The public care will not be charged. All medication and scans that are done in that clinic will not be charged. However, when it comes to treatment, there may be a variable number of treatments that might be suitable for you. And some treatments which may involve particular applications to ethics committee and things may have charges. When a treatment is offered, it may mean you have to decide between things such as the use of donor eggs or donor sperm, depending on what gives you the better chance of pregnancy. But that would still usually be included within the public costs. If treatments such as ovulation induction or IUI is used, then one treatment and up to another 3 treatments for a total of 4 may be included as a package. And sometimes you're asked to say, well, we think this is the better treatment for you, but if you take up that public funding option, then if it is not successful, rather than being eligible for 2 IVF treatments, you may only be eligible for 1 in the future. These things should be carefully explained. Even things like gestational surrogacy, where a woman carries the embryo from a couple rather than for the couple themselves carrying the pregnancy, can be covered in public funded care. It can be very confusing. As I've said, the public funding covers up to 2 packages of treatment, and that package could be 4 IUI treatments or just 1 IVF treatment. What is a cycle? If it is able to proceed to the point where insemination is performed in an IUI, or where an embryo is achieved after fertilizing eggs, then that counts as one of those treatments. If there is a baby born and all is well, then further treatment may be possible, but it will require further assessment to see if you are still eligible. And that's because the point scoring system takes into account the birth of children. If you do not become pregnant from that first series of treatments, you will be scored again using the same criteria. If you've had a child even from private care whilst waiting for the public system to treat you, that will still be taken into account and could alter your eligibility for public care, even if previously you were advised you would be eligible. Your fertility specialists will go through these details and should provide you with the actual point scoring and why you are eligible for public funding or not. If someone's been through IVF, about half of the patients will have embryos frozen and stored from their first embryo transfer. If they'd actually undergone private IVF treatment and then become eligible for a public treatment, they may be asked to use their frozen embryos even though they were previously collected during private treatment. That may be required before public funding begins. Remember that things like smoking and BMI will be reassessed again at the start of treatment. If someone has gained weight or recommenced smoking, it may delay their care. Even if you've met all the criteria and something has changed, or during treatment it appears that the treatment may not be successful, such as the medications aren't working well, you may be reassessed and it may be that a different form of treatment is offered, or perhaps you may not be eligible for further treatment. Most people have no cost, but I did mention that there may be legal costs in some situations, such as the use of a surrogate or donor embryos, or some treatments that are novel and almost research treatments in New Zealand. That's because we have an ethical committee that approves such things, and they do often request a legal opinion before these treatments can go ahead. If you do complete IVF and you have spare embryos frozen, the storage of these is paid for with public treatment, usually for the first 18 months. But if you do not use those embryos in the first 18 months, you may be asked to pay for their storage. These costs are usually a few $100s, but it is important to ask and realize what that cost might be. Private treatment encompasses a lot of different issues. It is often quite confusing when one looks at the websites or the written information you're provided. Prior to treatment, you're still required to have a number of tests that you would be for public care. However, extra things such as scans, genetic testing, or sometimes special semen tests and preparation of sperm to see if IUI would be effective may have costs. The freezing of sperm has a fee for the actual freezing procedure and for its ongoing storage. Counselling is provided at clinics, and just as with other health practitioners, there is a fee if this is undertaken in private. With private funded treatment, there are a number of issues that could be given. In particular, just monitoring the cycles or tracking them has a cost. It can be quite variable as to whether medications and scans are used, because sometimes the medications can amount to several $100s. IUI almost always involves medications, and this preparation of sperm means that it will indeed incur an extra cost beyond just tracking the cycle. And so the difference between perhaps cycle tracking, which might be a few $100s, IUI is normally more than $1,000. IVF treatments in private range in cost to a great degree. The treatment, such as collecting the eggs and fertilizing them, may represent the majority of the cost and may be about $8,000. But the medications can vary from a few $1,000s to more than $5,000 and an essential part of the treatment. Private funding often includes the possibility of more than that which is offered in the public service. The frozen embryo transfer cycle, which has no cost in public, may have a cost in private to monitor the cycle and thaw the embryo. Also, there are other things described as add-ons by some people. And this may be extra lab procedures, such as assisting the sperm to fertilize the egg, or procedures to do with the special freezing of eggs or embryos. Others require attendance in an operating theatre for a full anaesthetic or special genetic tests. If a man has sperm produced in the testes, but there is none in the ejaculate, then sperm can be collected surgically, either under local anaesthetic or under a general anaesthetic. But both of these things have costs if they're done in private. And in this way, an IVF cycle combined with these further add-ons could easily exceed $15,000. I've got 2 or 3 scenarios here I'm going to talk about. Amy has asked regarding what is the waiting time for first specialist appointment. So before I come to these scenarios, I'll just mention that each health board has a process of assessing those first specialist appointments. Some will be seen in the public hospital before then proceeding on to a clinic if they are eligible for funding. If, however, it's done in private, as in the Northland Regional Health area and in Christchurch at a private clinic, often a first specialist appointment will be seen within a matter of weeks to months. but usually not more than 6 months. So first specialist appointments, if the criteria met, are usually seen promptly. However, once people have been seen, if they are eligible for treatment, the time between they have been assessed and when treatment starts varies quite a bit. And this is where these scenarios explain things a bit more. If tests are undertaken by your general practitioner or by the public hospital or in private, they don't always give an answer. So this unexplained fertility delay is very frustrating. It affects probably about a third of couples, and yet there is still public treatment available. The public care, however, will only be possible when more than 5 years has elapsed from when you last used contraception. And it means that that delay from the first specialist appointment, whether it be a few weeks or months, won't affect the time you become eligible, because the waiting time is determined from when you last used contraception. But even when that 5 years has elapsed to get enough points to be eligible, there is another delay until treatment starts. And that treatment may start within 6 months, but currently in several of the health boards and private facilities now, the treatment takes about 1 year to 18 months to be initiated. So for that couple with 5 years unexplained delay, they may not in fact be offered to start their public treatment until more than 6 years since they last used contraception. The second scenario is when there is something obvious preventing fertility. If a man had a very low sperm count, or if a woman had blocked fallopian tubes, then waiting is not going to achieve a chance of pregnancy. Whereas in that unexplained group, there remains an ongoing chance, and that's why that waiting time was part of the criteria that the government uses. But without sufficient sperm, then there is no point in asking the couple to wait. However, if they achieve the number of points to get eligibility, usually they will have still had to wait a year before that treatment would be planned. And in that scenario, it can be between about 1 and 2 years without contraception that the treatment might be initiated. What about people that come in between those two options? If we look at things and realize that someone may have a disorder such as endometriosis or variable sperm quality, they are neither in the unexplained group nor in the definite absolute group. And this couple will often get a score that means that with time, they'll become eligible. The time won't be 5 years, but won't be the 1 year that the absolute cause has. And in this circumstance, it might be about 3 years, but that's still a long time to wait. And that's why it should be explained to you where you fit with the public funded system. In terms of the price of things, when we come back to that other slide, I'm well aware I put in estimates, and that's because there is a wide range. But with IVF medication, if someone is a good responder that may make several eggs, it may be that only a low dose of medications is required. And in that circumstance, the cost might only be $2,000 or so to have eggs collected. But if someone has a situation where the ovaries are less responsive, the increased dose of medication to stimulate the ovaries could easily put that medication bill up to $6,000. The test that I mentioned, the AMH test, does give some indication. It's really a measure of ovarian reserve, and that means the number of eggs that are stored within the woman's ovaries. At birth, the woman is born with about 2 million eggs. But each month, even when she is before the age of puberty, about 1,000 or so eggs fade away. And then once ovulating, only one actually matures. So if we look at the number of eggs that someone has at a particular age, it is slowly lowering from the time of her birth. The AMH test gives some indication of how many eggs remain, but also how that woman might respond to medication. And in that way, if someone looks very responsive, a lower dose of medications will be necessary. If someone, however, is at a stage that their ovaries will have a lower response, a higher dose might be suggested, but even with that higher dose, only a few eggs might grow. Although this is very stressful for anyone involved, it is still a matter of quality, not quantity. And so those women who are at a younger age often make a better quality egg in terms of the chance of pregnancy than someone in their late 30s or 40s. These things will be explained at a clinic, whether it be in public or private, but it does influence why that cost varies. I've been asked how old is too old for IVF. In terms of someone's own eggs, there have been very few pregnancies over the age of 47 in the world. We realise that unfortunately, although women continue to ovulate often until their 50s, the chance of pregnancy diminishes naturally, and it does diminish even with IVF eggs. Indeed, if we look back at a chance over age for different women, it's an average. It doesn't predict for any one person, but generally, the likelihood of an embryo implanting is less for someone aged over 35, such that the embryo may look the same down the microscope, but the implantation rate for someone aged 40 is usually less than for someone in their early 30s. It is for this reason that government funding is limited to women under the age of 40. However, there are many pregnancies for women over the age of 40, but it may take more than one egg collection. And yet the unfortunate thing is they may be making fewer eggs at that time. The implantation rate for an embryo does relate to age. Yes, it is possible to do further assessments in a laboratory and even tests such as genetic analysis. And each laboratory has got clear results as to what they would expect for a given age if it is a healthy embryo. I think that women should take that assessment rather than relying completely on age, but I'm well aware that once a woman is over the age of 43 or 44, the chance of miscarriage almost also increases, which is a distressing part of this treatment. So pregnancies may be achieved, but the key issue is really that healthy live birth. In terms of PCOS alone would not necessarily alter someone's scoring and eligibility for public funding. It may be that women can have that appearance of polycystic ovaries, but not influence their fertility at all. The PCOS means that there is some other aspect rather than just the appearance of the ovaries. And it may be irregular menstrual cycles or lack of ovulation. In that circumstance, regular ovulation might be all that's needed to achieve a pregnancy. So it's not the diagnosis of PCOS itself, but how it's affecting that individual. And in particular, ovulation is the commonest factor that has changed with PCOS, but there are others as well, such as weight gain, changes to diabetes or sugar control, things that are actually quite important to someone's health. In terms of younger women, particularly if someone were to be diagnosed with cancer, there is public funding available. There is not waiting time according to normal criteria, and usually people are seen within weeks to discuss with the clinic what can be done to help. It may be possible even before chemotherapy begins or any other surgery or so forth were to begin, to actually harvest eggs and freeze them. It is not necessary that someone needs to be in a relationship. These may be single women and someone who has not even considered starting a family. It is, however, important that those tests, such as an ultrasound scan and AMH, would be done. It's also important that the woman has to discuss the issues, because of course the priority is managing their cancer. And if it is an ovarian cancer, the treatment may damage her ability to make further eggs or achieve a pregnancy. Then again, it's not always straightforward. And the combination of information from the oncology specialist, the surgeon, and the fertility clinic will normally come to some advice that suits that individual. There are some women who can indeed undergo chemotherapy rather than surgery, or defer treatment whilst planning to either harvest eggs or achieve a pregnancy. But it has to be specialised for each individual. The same applies for men. If men were to be diagnosed with cancer, sperm can be frozen with public funding. It may be that once they have overcome their cancer, it would be suitable for IUI or IVF. They do not need to have a partner in order for this to be undertaken. And that's why indeed freeze eggs or sperm, or even embryos if couples are already prepared to go through IVF prior to those cancers being treated. I've been asked, how do FSH levels impact on IVF? And FSH is the hormone from the ovary that at the start of a menstrual cycle initiates egg development. The eggs are stored, but they start to grow. They've indeed probably been preparing for growth a few weeks earlier. But as those FSH levels rise and egg develops, once the estrogen is rising produced by the ovary, the FSH diminishes. As women get older, they do make more FSH naturally in order to achieve the development of one egg. So if we were to measure an FSH level for someone aged 45 compared to the levels that they might have made when they were 35, they are usually higher. It means then, as the FSH rises, it may be fewer eggs. The AMH, which is a measure of egg numbers, is probably decreasing. And these two influence the specialist to decide what dose of medication might be necessary to get eggs to grow. FSH is quite variable in the cycle and sometimes needs to be repeated, whereas AMH doesn't vary as much at all and is usually similar if it's repeated 1 month to the next. The FSH levels used to be the only measure we had, but really AMH has now been available for about 15 years and provides a lot more information for IVF treatments than just FSH alone. They're both useful. They also provide information combined with what's found on an ultrasound scan when the appearance of the ovaries, measurement and counting of small follicles, these are the egg-containing follicles, before they grow, gives us a number called the antral follicle count. And in this way, the health of the ovaries, the reserve of eggs, can be estimated before treatment begins. In summary, I will come back to 1 or 2 questions after this, but public funding has really got quite strict criteria. It's confusing, and I believe that many of us, specialists, and certainly others in the community, actually find it quite confusing at times. The waiting time for treatment can vary between those months, perhaps in a cancer situation, or weeks, but more than 5 years for some couples that have got no obvious cause. The private treatments have a lot more options, but there'll be a cost involved with those treatments. In general, the treatments that are provided in the public funding are the most proven and usually the main ones that will be required. Some of the private treatments may be on a research basis that still have doubts about their effectiveness. The actual cost is variable, and one of the things that can be stressful is that during a private treatment, even though one has been explained what the cost might be, it can actually change while the treatment, if the medication changes or if the treatment in the laboratory changes, such if there was to be a poor sperm count on the day of insemination, some extra treatments might be necessary to get those eggs to fertilize. I think that both options should be well explained and the details provided in writing. If it's confusing, most clinics actually provide extra time or extra staff just to discuss those costs. And I think it is important to discuss those because it can be quite a stress along with all the other medical issues that are going on. In terms of this treatment and why it might be used, there are many research papers looking at what would be the best option. And I've been asked, what is the difference between success rates for IUI versus IVF? IUI treatment was initially thought to be useful for those men with a low sperm count. Further research showed that it probably gives it best chance for those couples with unexplained delay, with a good sperm count, for a woman who's got healthy fallopian tubes and is ovulating. We realized that the sperm count varies a lot, and sometimes someone with a good sperm count may indeed have a poor recovery once the sperm's been washed, ready for insemination. So it was then apparent that looking at the numbers of sperm that were actually inseminated made the difference. Whether it be combined with medication or natural cycles does influence outcome, but many people may achieve pregnancy with IUI if more than 1 or 2 million healthy spring sperm can be inseminated. Most of those treatments, if they are to be successful, the pregnancies will occur within 4 treatments. They don't need to be month after month. The chance remains the same over 4 treatments. Hence that package of 4 has got a scientific basis on why it's been advised. The chance does relate still to the woman's age, but one might expect perhaps a 15 to 20% chance of IUI being successful. We can't just add that up and say, well, 4 times that will be a 60% chance. But for some couples who achieve pregnancy easily with IUI, it's a lot less stressful and less expensive than doing IVF. The success rates for IVF depend on not just the sperm numbers, but really the egg quality, the embryo quality. And in this way, looking again at a woman's age, we would often expect an implantation rate for one embryo transferred to be about 50% for a woman aged under 35. If, however, the couple were aged over 40, the implantation rate may be as low as half of that 50%. And that is still similar almost to what might be achieved with an IUI cycle. However, the cost of IVF and the timing of how it is coordinated is quite different. So IUI is a less expensive option, but has different criteria. IVF will be used for those couples who may have failed IUI, who have got other reasons why they don't wish to proceed to IUI, such as scarring of fallopian tubes or variable sperm counts. There's a lot of research in these areas and a lot of numbers. In Australasia, the results are published each year from all of the clinics, and essentially it is possible to learn the expected pregnancy rates for a given age, what we would expect for these treatments on average. There is still a variability, but it means you should be able to get up-to-date information that is particular for your own situation. I've been asked that, can I ask the lab to do an AMH test yourself? And yes, you can. It's something that the GP should really request, and it may be the laboratory would ask for a doctor to sign for that. And so you don't need to be under a fertility specialist, but any local general practitioner can request that test. I think it's a useful test for any woman over the age of 35 to actually have done. It may need to be combined with a scan to be properly interpreted, and certainly for younger women who may have had surgery on the ovaries, such as for endometriosis, or if they've indeed got irregular or anovular menstrual cycles, that is an important part of their assessment at any age. I think that it's a useful test. It should be combined with advice, and that's why sometimes just doing a test alone from a general practitioner may not be as easy to interpret. But it's a commonly used test now, and there are plenty of websites available that would give good explanation. I've then been asked, if going through public funded treatment, can you opt to pay for add-ons, or what does that mean? This is really quite a particular request that is covered within the contract that the health boards provide to the private clinics. Some add-ons may be included if deemed acceptable to the health board, but they do like to be made aware of what indeed is being offered and what it's costing. And in the past, many of the treatments that are now offered as routine were at one stage not covered by the public contract. So whoever is providing the care would advise you whether it is possible for these to be paid for privately. But generally, it has been something that has been carefully audited in order to be certain that the offers that are being made are realistic and not just a matter of providing extra care where it may not always have the research to support it. Someone's asked me specifically if the poppy seed oil fallopian flush is part of funded treatment. At the moment, I don't believe it is. It's something that, although there is proven research to support it, the cost of the Lepardo procedure itself amounts to several $100s. I'm aware in our own health board it is not funded. It's something that may, like other treatments and investigations, be incorporated in the future, but I don't believe it's being funded elsewhere. As the research was originally performed in Auckland, it may be there is a better option within the Auckland clinics, but I know that in my own region it isn't. I've been asked whether public funding, where a woman may not be able to produce her own eggs, are the donor fees covered? Indeed, if that is the recommended treatment, I believe it is covered, but it is essential that the assessment of the person for whom will be the recipient is made thoroughly. And why that is because the treatment of donor eggs has to be undertaken carefully. The couple for whom the donor egg treatment is required will have to go through counselling, and it's something that, yes, donor eggs may be their only treatment option. This is very similar to a man who may have had chemotherapy or some injury and has no sperm. The donor sperm treatment is part of public care. How often should one repeat AMH tests? Realistically, they don't change very quickly. And because it's just an indicator to response, I believe there's no need to repeat a test within a year. Then again, if someone has got a particularly good level, it is unlikely to change, unless perhaps there'd been surgery on the ovaries, within a few years. And so it's best to look at it in context of a graph of someone's age. And if someone, say in their 20s, was to have a test that was in the normal range, they can probably be reassured for several years. The difficulty arises when someone has a test that's low at any age, because if it is low, it may mean they would produce fewer eggs with IVF. And in some circumstances, this may actually preclude public funding, because if they're not going to respond well, they may not be eligible to proceed with IVF, and they may be asked to consider donor eggs. If it was possible, a repeat test should probably consider within a year, but it does need careful discussion, and I think it needs to be taken in context of how the ovary responds. There are situations where sometimes people have had a low AMH and respond well. Particularly for younger women, the quality of the eggs may be a good quality, even though they've made only a few. The converse is true for older women. Sometimes there may be a good AMH, but only a few eggs of quality may be collected. And so AMH is only a marker. It's not really the answer. Would the drugs to stimulate ovulation for someone with PCOS be counted as one of the rounds of public treatment? They may be. And in the past, ovulation induction treatments were included and paid for by the government separate to the fertility budget and the contract to the private clinics. Whereas now, ovulation induction is treated as a package of perhaps 4 or 6 cycles. And it may be that if it's just to achieve ovulation with natural intercourse, that couple may be able to go through several cycles. But if IUI is to be combined with ovulation induction for someone who's not ovulating, then there would only be usually 4 cycles. And these are the sort of things that are defined within the contracts between the health board and the clinic providing the public service. And that would be possible to ask them if the underlying factor is irregular or absent ovulation, how many cycles would be funded without IUI, so just achieving pregnancy with intercourse, or should it be IUI with ovulation induction? Generally, ovulation induction alone has a high success rate for those women who are anovular. They do not necessarily need to have IUI, particularly if their partner has a good sperm count or may have had a history of fertility in a previous relationship. Then someone's asked me, how much does Clomid cost? Clomid can be prescribed by any medical practitioner, and the standard fee in terms of the prescription is about $15 from a specialist, and it may even be less from a general practitioner. It has been used for decades and has a high success rate. Whether it be combined with metformin remains a debate, because metformin is a hormone or a medication that alters the insulin and its effect on the ovary. When it was first promoted, it looked very promising as a treatment by itself. It certainly does help blood sugars, but our success rate with ovulation induction over the years worldwide has meant that metformin is not used as much as it was originally. The metformin prescription is about the same. The standard general practitioner cost or standard specialist cost. An alternative to clomiphene, which is often used now, is a drug called letrozole. The reason why it has replaced clomiphene is because often clomiphene can result in more than one egg being produced and has a higher chance of a twin pregnancy. And ideally, the safest pregnancy is a single pregnancy. By all means, we would like people to have more than one child in their family, but it's best to have them one at a time. And so for that reason, the aim is to achieve a single follicle with a single egg and achieve a pregnancy that way will probably result in a better outcome than running the risk of twins or more with fertility drugs. And that's why monitoring and the use of low-dose letrozole or low-dose clomiphene is recommended. Then I've been asked, if someone had a really high level of eggs, perhaps the AMH would be high. Would this indicate they're not regularly ovulating? Quite often, we realize that of those women with a high AMH, it doesn't influence their general health, but it is a marker that if we then start looking for ovulation markers, such as the rise in progesterone for the second 2 weeks of a menstrual cycle, these women may not be ovulating. They often have good quality eggs, and with medication, or if there are other factors like weight changes that are required, may achieve pregnancy without any need for IVF or other treatments. And usually this can be managed by a specialist who may not be working within an IVF clinic. There's a sort of treatments available at public hospitals and by other fertility specialists who may not be involved with IVF. Someone's asked me about the changes in their AMH, how it went from 33 and reduced to 23 over 9 months. That is unusual, and I must admit I've seen such changes. I've seen them also go the other way, where someone may have had a level, say, of 20 and has gone to 30. What's possibly important here is to also look at how that fits in for that particular age group, because both of those tests may still have been in the normal range. It's when the AMH lowers to single figures, so less than 10, that we get more concerned about diminished ovarian reserve. And yet both 33 and 23 would be reassuring for most women, but the worry would be, is this going to progress to be an even lower number? And in that situation, I think combining it with the details of the scan and perhaps even repeating that test in the future would be a good thing to do, because it is just a marker and it's not the whole answer. But I'd sort of suggest that it can be concerning and discuss it further. And that's the times when sometimes we do repeat AMH. I don't know that questionnaires age, but if there's someone who's perhaps under 30, I would not be too concerned. I would probably just repeat it again in a few months' time. I've been asked again about the clomiphene. Yes, that can be prescribed by a general practitioner, and it can be prescribed by other specialists, including endocrinologists and gynecologists who are not necessarily involved with IVF. Although general practitioners can prescribe it, over the years we have been concerned that sometimes the twin pregnancies and the other risk factors may occur if someone's not completely used to using it. So usually it may be prescribed by a specialist with experience in fertility, or if a general practitioner is able to have advice from a specialist, perhaps from a public hospital, who initiates the treatment and then asks the general practitioner to continue it. In this way, the cost may be just for the prescription alone, but if there is a risk of over-response of multiple pregnancy, then it's best monitored by a fertility clinic that can do scans and interpret blood tests. And that's why over the years, clomiphene has been more often prescribed in a specialist situation than in general practice. A further question is, if a couple with a male factor, perhaps a low sperm count, and the woman has a good reserve of eggs, say just above average, does that mean that the cost of medication will be at the lower end? Probably. However, the difficulty is until the medications are given, one doesn't really know. There are times, as I've said, that people have had a low AMH and gone through the anxiety of thinking, oh goodness, this is going to cost more and I may only get a couple of eggs, and indeed they do well. There are other times when people look at the AMH and assume because they've got a high level and perhaps a very favourable antral follicle count that they won't need many medications and they'll make lots of eggs, and they don't. I still believe the key issue is quality, not quantity, and that worldwide, when people looked at the number of eggs that are collected and averaged them out, it would appear that that is matched by the results. Those women that make perhaps 8 to 10 mature eggs often do better than the person who makes more than 20 eggs. They may have a number of immature eggs. So I think that the skill involved by the fertility specialist is to get the quality eggs to grow, not just go for the numbers. And that's why sometimes less may be better. Just getting 2 or 3 good quality oocytes rather than 23, of which many are immature, may not be in anyone's interests. Can a GP prescribe letrozole? Does that have to be through a specialist? Letrozole is something that's really only recently been introduced in New Zealand. And even now, there's a little confusion about its usefulness. I believe that it would be best prescribed by a GP in conjunction with a specialist to oversee it. It can still result in a twin pregnancy, and there are indicators of when that might be. And so usually it is monitored with blood tests or scans when it is initiated. And from thereafter, a GP could prescribe it, but I think it would be best that they probably work in conjunction with a specialist. One of the reasons is that if pregnancy hasn't occurred after a certain time, is there something being missed? Should there be further investigations, or should that woman perhaps think of an alternative treatment rather than just continuing with letrozole for many months? Now, there's a lot of questions that I realize that people may wish to ask that they wouldn't want to ask in this sort of forum. Fertility New Zealand does provide advice. As you may have gathered, I try not to give advice specifically about treatments, and realize that that should really be left up to individual practitioners who are looking after you. But sometimes there are questions that do get confusing, or the answers have become confusing with your own clinic. We'd like to support people. We're not trying to undermine advice that you've been given elsewhere, but certainly some of these issues, even over the funding, we're available to take questions, and it may be a private question you would need to forward to us. We'd be able to discuss those things, but we'll usually try to provide an answer that's useful to the care that you've already been given, rather than trying to change advice drastically. Most of the practitioners in New Zealand who are involved with fertility treatments are very experienced and have heard most of these questions many times. So I think that please feel free to ask us questions, but also ask your caregivers. Ask the nurses, and some of them are very experienced and able to explain things in a way different to the doctors. So keep asking questions, get things in writing, because often that helps explain. And by all means, look on the internet. But what I do say to others, if you look on the internet, be careful. You tend to find what you're looking for. If you're looking for bad news, you'll find it. But if you're looking for good news, you'll find it. University websites often have a very balanced research-based advice. And some of the things that you'll find on the internet promising things that are too good to be true usually are. All the best.
Thanks, Greg. That was a great presentation. So thank you very much for your time tonight as well. This does wrap up our webinar series for Fertility Week, and all of our recordings will be available on our website and Facebook as well. So once again, Greg, I just thank you so much for a very informative presentation. It's been great. The comments tonight have been, the questions tonight have been really full on and busy for you. So thank you so much for your input there. And as Greg did say, we are here to support you and to help with any questions as well. So yeah, please do get in touch if you do need any further support. So in saying that, I'd like to say good night to everybody, and thank you once again, Greg. So good night.
Thank you.